Hello everybody, I'm Babak, an anesthetist currently working as an associate professor at AAGBI, the University of Medical Sciences in Tehran, Iran, with a 2-year experience as a P Fellow, a senior registrar in Melbourne, Australia. I have reviewed protocols from different countries on Covid-19 and have summarized their common recommendations in this slideshow. My colleague Dr. Laleh Ali Marvasti will narrate the slides for you, and we hope it will be helpful to you.
In literature, Covid-19, Corona and SARS-CoV-2 are being used interchangeably. Specific for this presentation, we will apply C19. We utilize data from different resources, including Iranian Ministry of Health, Australian Society of Anaesthetists, World Health Organization, and the Association of Anaesthetists of Great Britain and Ireland. C19 was first reported in Wuhan, China in the late 2019 and declared pandemic by WHO on 11th of March. It is an enveloped double-stranded RNA virus assumed to be zoonotic. Viruses S-spikes attach to type 2 pneumocytes, and in addition to the lung, GI tract has also been considered a route of transmission. From those who are affected by C19, about 15 to 30% present severe symptoms and signs, and its overall mortality is around 0.5 to 4% worldwide. From those who end up in ICU, approximately 25 to 40% will develop ARDS, or acute respiratory distress syndrome, and about 50% will pass away. The incubation time of this virus is between 2 to 14 days. The median hospital stay time has been reported to be 12 days. C19 is mostly transmittable through person to person by contact and droplets. Droplets are large particles that can't travel long in air. However, during aerosol generation procedures, or AGPs, such as intubation, extubation, upper GI endoscopy, non-invasive positive pressure ventilation, or NIPPV, bronchoscopy, tracheostomy, high-flow nasal oxygenation with oxygen flows greater than 6 liters per minute, CPR, dentistry, and the use of nebulizers, the transmission is suggested to be via airborne particles. Now, airborne particles will linger for a long time in air, are less than 5 microns in diameter, and can travel up to 4 meters in distance and have the chance to reach human alveoli. Indications and correct utilization of PPE, or personal protective equipment, plays a key role in C19 for protection of the patient and the personnel. For C19 suspected or confirmed cases who are undergoing an aerosol generating procedure, the medic or nurse should wear full covering, including hat, gown, N95 or P2, face shield or visor, and gloves. During the procedure, try to minimize the presence of personnel and preferably treat in an isolated negative pressure suite. The risk of airborne particle exposure is suggested to stay within the room for 30 minutes after cessation of the procedure. In non-AG procedures, a simpler PPE may be sufficient. To protect the patient and mitigate the patient's risks, the patient should put on a surgical mask until the time of pre-oxygenation. For donning and doffing, we should adhere to protocols and keep in mind that for removing the PPE, the order would be gloves, goggles or face shield, gown, face mask or PAP, and finally hand hygiene. It is recommended to use PAP instead of N95 masks. However, you can make exceptions, for example, if it's not available or difficult to use, or if you're staying for more than 1 hour to perform AGPs on suspected confirmed C19 patients. Clinical presentation of C19 is variable. Most common manifestations are fever, dry cough, and fatigue, and sometimes a sore throat. WHO criteria for severity includes a respiratory rate of more than 30, O2 saturation of less than 93, and a PF ratio of less than 300. In lab tests, WBC can be normal while having lymphopenia, with elevated CRP, LFT, creatinine, D-dimer, ferritin, and interleukin-6. Bear in mind that children can have slightly different manifestation. For its diagnosis, the most available test is nasopharyngeal swab polymerase chain reaction, or PCR, worldwide, which has a sensitivity of around 70%. Image of ground glass opacity in CAT scans has a higher sensitivity. Also recently, finger prick at point of care, or POC, of IgG has shown to have a higher sensitivity. Regarding airway management, most centres accept a PF of less than 150 as an indication for invasive mechanical ventilation, or IMV. Reaching the point that intubation is indicated, once we reach the point where intubation is indicated, it is necessary to formulate a plan, prepare equipment in advance, apply available checklists, and have an effective team dynamic. For airway protection, early intubation decreases the risk of crash intubation, which would be undesirable for C19 cases. Cuffed ETT is preferred over supraglottic devices. Videolaryngoscopy with disposable blades should be utilized. Some recommend placing a simple plastic cover over the patient's face to lower the risk of cross-contamination in case of coughing. To lower the risk of coughing and facilitate an easier intubation condition, perform rapid sequence induction with full relaxation. If bag mask ventilation is needed, perform it bimanually as shown in the picture, with minimal gas flow required to maintain oxygenation. Plan for first success by getting the most expert person to do the intubation on first try and preload the ETT with a stylet. To lower the airborne exposure, double filter the circuit and remove face mask with its attached filter as one unit, then connect it to the circuit to the ETT. For COVID-19 patients who require surgery, consider regional and neuroaxial anesthesia as a first choice. If it is indicated, patients should wear surgical masks throughout the procedure. Nasal prongs with oxygen can be administered from under the surgical mask. Test coagulation profile in severe C19 and obstetric patients. In those over 65, check clinical frailty score. Be cautious about its shortcomings, including patients with disabilities and difficulties in communication. If CFS is more than 5, discuss the end-of-life care and the possibility of struggle for post-operative HDU and ICU availability, and then come to a joint decision. In pregnancy, there is no evidence to support vertical transmission of C19. Labor epidural can be done safely after checking for coagulation tests, and this is recommended to be done early. After the delivery, there are some concerns regarding baby-mother skin contact transmission of this disease, which needs further research to be fully elaborated. Some protocols advocate C19 tests for newborns, as well as 14 days of monitoring symptoms. For pediatric cases requiring surgery, the patient and the accompanying person should wear PPE with a surgical mask. Symptomatic parents should not accompany the minor. Consider sedation and EMBLA, but be cautious in unwell kids. For children's airway management as per adults, to reduce the risk of exposure, cuffed ETT should be applied by the most expert person to gain the greatest success on the first go. Fitting masks, low flow, rapid sequence induction, videolaryngoscopy, double filtering, and minimizing the attendance of personnel is of course advised. After the end of surgery, consider deep extubation, minimize crying, and use Hudson mask or nasal prongs under the surgery mask. It is recommended that the anaesthetist stay in the recovery room with the nurse, as the risk of deterioration is higher in C19 patients. In ARDS is managed as per Acute Respiratory Distress Syndrome Net 2000 protocol, adhering to low tidal volume of 6 ml per kg of ideal body weight and low peak pressure, titrating PEEP in accordance to FiO2, utilizing recumbent maneuvers, prone position, and ECMO are all advised. The goal should be a rise in PF and a respiratory compliance or a decrease in PCO2. Permissive hypercapnia is allowed by monitoring pH to as low as 7.15. In terms of fluid therapy, we should keep patients towards neutral or negative fluid balance and support hemodynamic by vasopressors if needed. Muscle blockers have not been shown to decrease mortality. However, temporarily should be applied to fix hypoxemia, ventilators dysynchrony, and high airway pressure. Although many treatments have been used for C19 anecdotally or as trials, none have been as effective for sure. Antivirals, hydroxychloroquine, antibacterial steroids, and immunomodulators, IVIG, convalescent plasma are all under investigation in large trials for their efficacy. Hopefully the results will be released in a few months' time. However, we should all keep in mind that simple things can save lives.
Until now, age has been considered as the major prognostic factor for COVID-19. Other variables such as underlying diseases, namely cardiovascular disease, diabetes mellitus, hypertension, in addition to abnormal laboratory findings at the time of admission, can all play a role in the disease prognosis. In our experience on more than 500 cases over the last 2 months, my clinical opinion is that we attained good patient recovery with hydroxychloroquine, atazanavir, ritonavir, and interferon in advanced C19 disease. Other therapies such as convalescent plasma and IVIG showed modest results. Trials are still undergoing and we are all waiting for strong evidence to emerge. Adhering to treatment protocols are essential. However, for a pandemic like this, when evidence-based medicine is yet to come, flexibility and continual communication between hospital teams in the treatment approach should be permitted so that the medical team can make informed decisions that may be life-saving. This flexibility in protocol may have helped us in containing the crisis and reducing mortality when ICU beds were scarce. I would be glad to read your comments. Please email me on babak@gmail.com.